Thank you very much. Thank you very much for inviting me today. This is going to be a slightly different 45 minutes. We are going to discuss a case, but I want to encourage a discussion about how, as clinicians, we interact with evidence in clinical trials, and a lot of the discussion will be around trial data that came out over the last 5 years or so, and our interaction with that. So this is where I work in London, University College London Hospital, and here we run a tertiary hypertension clinic for the surrounding area. And just to start, let's discuss a case, one of our patients that was referred 5 years ago, in 2012, by her general practitioner. So she had a background of hypertension for many years, as well as many other issues. So she had a meningioma in 2008. During the operation to excise that meningioma, she had an episode of VT, which means that she had an ICD inserted thereafter. And luckily, has had no further episodes of VT since that was put in. There's a questionable diagnosis of epilepsy. The neurologists aren't sure if she does. She again had a single episode, but ended up on treatment. And she has type 2 diabetes, but only on tablets, not on any insulin. So when she was sent to our clinic, she was on five different medications. I don't know if anyone at this very early stage wants to comment on the combination of drugs that she was on. This was all managed by the GP. So she's on both an ACE and an ARB, as well as a calcium channel blocker and a diuretic, and a beta blocker. So she's on 5 agents. She's also on metformin and sodium valproate. So in clinic, after the history was taken, it was found that actually she's pretty well. She gets the occasional headache. And she has no significant family history of high blood pressure. She's slim, got a BMI in the normal range, and as per the GP referral letter, in clinic, after repeated measures, she really did have very high blood pressure, so 195 over 110. But there was very little else to find on cardiac examination. There was a description of grade 2 hypertensive retinopathy. Now, at this stage, as I'm sure many of you in this room do, we undertook some baseline investigations initially. And again, these did not reveal anything untoward. She had a normal blood count, her renal function was normal, very mild proteinuria, and surprisingly, her echocardiogram did not show any evidence of LVH, and that was also true of her ECG. Now, what would you do next working up patients with resistant hypertension? We routinely would perform ABPM, and we were doing this 5 years ago, to have a look whether patients have white coat hypertension. And she most definitely did not. Her blood pressure was sky high at this stage. Now, that's a mean blood pressure of 190. She did have a low blood pressure at one stage of 118 over 67, but you'll note that over 90% of her blood pressures were in the sort of poorly controlled range. So here we have somebody with a diagnosis of resistant hypertension. She far exceeds the definition in the European guidelines. She's on 5 medications, including the diuretic, and her blood pressure is sustained.
Professor Stassen wants to advise you.
Yes. I think this definition of resistant hypertension is a very loose one, and we should really leave it. I think without having checked the adherence of your patient, you cannot talk about resistant hypertension. It's as simple as that.
You're right. So that's exactly the way we approach this. So we approach this by saying this person appears to have resistant hypertension, and I'm sure it's the experience of many people here that this may be pseudo-resistant hypertension. So as I've put there, that she is failing to adhere to prescribed treatment.
Sorry, could I just ask, did you show us her nocturnal blood pressure? Did she have dipping?
No, she didn't dip to a normal degree. So she still had a degree of nocturnal hypertension as well as sustained hypertension, both 24-hour and daytime.
I'm from Poland, Urszula Czubek, Kraków. I think that the echo in this lady, it doesn't describe any hypertrophy. If she really have resistant hypertension, she should have hypertensive left ventricle. Yes. So for sure she is a failure in adherence of her treatment regimen.
And I think I normally would agree with you. I think this lady is quite unique in that even to date, so I can give you the up-to-date echo that was done a few months ago, she still doesn't have any evidence of LVH on echo, which is surprising when I show you the results of her other tests. And similarly, the lack of renal impairment is very surprising as well. And I don't have a good explanation for that. So there's no big reveal about why she has no real evidence of end organ dysfunction at this stage. So we all tend to think of at least two major causes of this phenomena. So first of all, is there an underlying cause? We've just heard about FMD. Does she fail to adhere to her regimen? If it's neither of those, then we can diagnose her with primary resistant hypertension. So obviously, the first thing that we do, we do all this in parallel, but of course we did a secondary screen. Now, a secondary screen in my institution, at the very minimum, after history and examination, would include a look at the renal arteries and the adrenal glands. Because of her ICD, this was done with CT rather than MR. It did not reveal any evidence of renal artery stenosis, and I can tell you this has also been reported and remains negative on a second look.
I would think that if someone takes 40 milligrams enalapril and has severe hypertension, finding renal artery, whether you find renal artery stenosis there or not, will in no way be helpful, as a response to ACE inhibitors is perhaps the best predictive measure of revascularization. So in my humble opinion, there's no point in looking into adherence, which makes much more sense than looking into renal artery.
And I'll show you her Renal shortly, which corroborates that impression.
Sorry, while we're waiting, did you say you did a renal ultrasound as well?
No. So we don't tend to go to renal ultrasound. So first line will be cross-sectional imaging.
Okay.
You didn't say about electrolytes, potassium.
So potassium was in the normal range. So again, when we look at her renal and aldosterone and the drugs that she's on, the fact that she consistently has a normal potassium. She's never at any stage been hypo or hyperkalemic.
No change. Okay.
So in terms of the rest of her workup, as routine in 2012, when she first came to clinic, we would do urinary catecholamines. This was done on 2 separate occasions and negative both times. I'm sure a lot of us have moved on to plasma readings now because of higher sensitivities. We haven't repeated that because of the 2 negative urine collections. Her renal and aldosterone was taken on medication, and I'm sure a lot of you are unsurprised given the result. She's on a high-dose beta blocker, dual ACE and ARB blockade, and this is what you would expect.
Microphone 2, yes.
Thanks, David Lappin from Galway. I have a couple of comments on the endocrine workup. I am a nephrologist, but did you deliberately do a CT adrenals in advance of doing the endocrine workup, or were they incidental? Fine. Did you incidentally look at the adrenals on the angiogram? So
when we request our cross-sectional imaging in all of our patients, we ask for both. So we asked if we can have a look at the renal arteries and also do a specific scan to look at the adrenal glands as well.
As you know, like scanning the adrenals without the biochemistry is probably putting the cart before the horse. The other thing about the catecholamines, did you check urine metanephrines as well? Because you'll miss a small percentage of PPGLs if you just do catecholamines and leave out the metanephrines.
Yes, we did. Negative. And I think the cart before the horse argument is interesting. I think the issue we have with a lot of our patients, and I'm sure everyone else does, is what do you do with somebody that's already on multiple agents which interfere with our interpretation of the renin and aldosterone, as opposed to newly referred patients where we can switch them over to alpha blockers quite easily and then get a more interpretable result. So I'm obviously interested to hear what your take on that would be.
Yeah, so there's a Dutch study recently showing that stopping medications in these very resistant people in order to do the tests doesn't result in any patient harm. Now, occasionally there's the odd patient, I think you can't do it, but in the majority of patients you can switch. I think the range of treatments she was on, beta blocker, diuretic, ACE and an ARB, this is not just a dirty screen, I'd call it a filthy screen. And we do try and interpret it, but I just actually think you cannot interpret it.
If you were to stop one of her medications in order to get a better interpretation, which one would you stop?
I think the beta blocker, probably.
Yeah, so that was our impression as well, because that's the only one that's really suppressing her renin. And in a lot of contexts when you're not sure if they've got a lump in their adrenal, whether it's functional or not, and you're in this context, we would obviously stop the beta blocker. And if the renin remained suppressed, then obviously your index of suspicion for primary aldosteronism is increased.
There's another subtle point on the calcium channel blockade. Dihydropyridine calcium channel blockers can block your aldosterone level. So ideally, they should be on a non-dihydropyridine calcium channel blocker, I think, if you really want to be clean about it.
Yeah, agreed. The ideal situation would be to do it on no medications. At this point, we would stop the beta blocker, and ideally, wouldn't be on anything.
And the final point is, both if you're extremely worried about this lady and don't want to stop it, and you think, Conn syndrome is the most likely endocrine abnormality you're going to come up with here, would just be to go to a peptidamidate scan and forget the rest of it.
Yeah, we occasionally send our patients up to Cambridge for exactly that. I think if we would have had a higher index of suspicion in her case, we certainly would have done that.
Okay, let's move on.
The presence of very low renin in the face of high dose of ACE inhibitor certainly indicates volume suppression. The presence of low aldosterone at this context suggests something else that substitutes aldosterone in causing hypervolemia, sodium retention, like licorice, NSAIDs. So I think at this point it would be, if not earlier, would be appropriate to go back to the patient and have some inquiries about her habits.
I have to say that's exactly what we were thinking, but the trick here would be to stop the beta blocker, so you know what the renin's doing in that context. Unfortunately, when we tried to do that, she complained of severe headaches and essentially started taking her beta blocker again. We tried this on 2 or 3 occasions and were frustrated by the fact that we couldn't get at least a look at her renin without the beta blockade suppressing her renin. So I'll obviously take a comment about the renin-aldosterone situation.
Dr. Khan.
Before discussing whether you can analyze renin-aldosterone on drugs, it would be interesting to know whether she has any drug concentrations at all. Otherwise, it's a theoretical discussion. And on that line, what about heart rate on your ambulatory blood pressure measurement? Because she should be bradycardic if she takes her beta blockers. And if not, that would help. And finally, we stop all antihypertensive medications, and it hasn't happened anything since 1987. If you are on 5 drugs and 200 systolic, nothing will happen.
Yeah, I think on the last point we could have been braver, certainly. There was some resistance from her. I'll show you some data in a second about her heart rate. And yes, we would love to have, we don't have the routine facility to measure, via mass spec, patients' metabolites of the drugs they're taking. And we know from studies in Leicester, for example, that 50% of patients routinely referred to these type of centres do not take their medications as prescribed. And there's other data that could be even higher than that, and I'll show you some of that in a second. What we do, actually, is we bring people into our day unit and watch them take their tablets and document that. So we do directly observed therapy. It's a lower phi version of doing that. And so I did this personally in a building that's actually now been knocked down at UCL. And because of previous experience, we are at this stage, when we did this, I think this was around 2013 with her, we were reluctant to give her all 5 of her medications at once. I'll show you why in a second. So we gave 3 of them at the offset. Now she's got a really high blood pressure initially, and her heart rate's 85. Now after the 3 medications, her heart rate did come down in response to the beta blocker to 70. Her blood pressure's not done very much at all. With the second 2 drugs, which now include a vasodilator, we do have a slight improvement in her blood pressure. But 5 medications in, I watched her take them. I'm pretty convinced. We left at 3 o'clock with a blood pressure of 205 over 105. So we were pretty convinced she had true resistant hypertension. Now, the next question I wanted to throw to the floor, really, is what would you do? What do you routinely do faced with this? Now, I personally don't think this is that common to find a patient like this who really does appear to religiously take her tablet. She's very trustworthy. We saw that her blood pressure doesn't drop. We haven't found an obvious secondary cause. She's already on 5 medications. This is 2012, 2013. What would you have done with her?
Yeah. We discussed about the use of beta blockers. Why don't you use, for instance, non-dehydropyridine calcium channel blockers? Because when we consider some biochemical measurements in those patients, we normally replace beta blockers or some other drugs with non-dehydropyridine calcium channel blockers, verapamil, the slow-release verapamil or the slow-release diltiazem. And when you use those drugs, then you may see probably even different blood pressure lowering effect. And in the meantime, you can also perform biochemical measurements more accurately. That's our routine work when we have resistant hypertension for some measurements of those for secondary hypertension.
Thank you. That's a good idea. I'll take that back.
You didn't mention the calcium. Presuming it's normal, our guideline would say add spironolactone. She had an aldorenin ratio of over 800 to 1, irrespective of whether she was on a beta blocker or not. She's not responding to a huge dose of enalapril anyway. And the other thing is either up the diuretics and or up the calcium channel blockers. She's only on 10 of lercanidipine. You could have used 20. You could have used nicardipine 45 BD. You could have added toracimide. But I would have added spironolactone. The guideline would say add spironolactone first, up the diuretic, and then up the CCB, and way down on the enalapril, which above 20 probably didn't achieve anything.
Yeah, and we also, you can't be 100% sure she doesn't have primary aldosteronism given the biochemistry, and we actually thought along the same sort of lines. So we initially added spironolactone, and also we saw that slight response to the vasodilator. And so we also thought some additional vasodilatory therapy with an alpha blocker might be useful. But this was also 2012, 2013, and I want to just switch things up a bit now and suggest something else that we thought about at that time point. And this is, I think the discussion is now going to move on away from the case specifically, and that is, should we consider her from renal sympathetic denervation? Now, that was because at this time point, this was very much in vogue, as I'm sure you can all remember. And just to go back quickly to remember the underlying idea here, it's that via various mechanisms, sympathetic tone both to and from the kidney help to drive up blood pressure. And that if we can endovascularly, or I've heard new technologies in other sort of transcutaneous technologies now, ablate these arteries, that we may affect a reduction in blood pressure. So that was the original concept. And if you recall, the very first catheter that was brought onto market was the Sympathetic catheter. And the idea was that you would ablate in a corkscrew manner, each bilaterally, both renal arteries, in order to ablate these. Now, I'm just going to take you through the two studies that came out at this time point that we had in our hands to help make this decision whether we should try this on our patient, this new emerging therapy. I can see a queue of people at the microphone, though. Is this a good place to stop?
Do you want to stop? Yeah, please. Let's take the first question.
Before going to renal denervation or other things, I would consider to optimize the medical treatment. The patient is taking enalapril once a day. We know that enalapril doesn't last 24 hours, the same for losartan. So first of all, I would optimize the medical treatment. Even like this, I think this won't be enough, and you will need more drugs like spironolactone, doxazosin, anything else. But the first step is optimizing the medical treatment.
Agreed.
Second, yes?
Yeah, I agree with spironolactone as the next line, but before even accepting the data that you had for renal denervation at that point in time, I mean, the trials were very, very poor. Patients were their own controls, etc. And it wasn't until hypertension 3 that we actually had proper trial data for it. And you still, even with that poor data, and a lot of people went ahead and did renal denervation, you still hadn't ruled out a Conn syndrome. And my own experience of this is when I've taken the renal denervation patients into my clinic, we've diagnosed Conn syndrome in a lot of those patients. It's never been clear to me at any point in those studies that the patients were properly worked up.
Yeah, and I think that's the beginning of a discussion that I think I want to throw a bit wider when we go through the actual data from the trials, the advice that was given nationally, which I'll show you. That in the UK, we had some guidelines published, which I'll touch on. And yes, we'll discuss some of those points a bit later.
Yes?
Hello, Philippe Delmotte from Belgium. I'd like to go back for just 1 second on the workup of this patient. First, do you have an idea of her urinary sodium levels?
I'm afraid I don't know.
No, because it's a known fact that low sodium diet is more effective in resistant hypertensive patients than in the general hypertensive population. So that could be one point. And my second question is, do you at any point in the care of this patient considered doing polysomnography to look for sleep apnea syndromes? Since you mentioned that she was a non-dipper, so I think that might have been interesting.
Yeah, so in terms of the sleep apnea, so she doesn't have the body habitus of somebody with sleep apnea. I think we don't do that routinely. We essentially ask questions about sleep, snoring, then we might use something like the Epworth or a first-line questionnaire. You'll see from our cohort that we do diagnose sleep apnea in our patients, reasonably commonly, actually. It seems to be obviously an increasingly recognized, and I think you're right, in retrospect, she's a non-dipper, so maybe she just doesn't have that body habitus or that sort of, those symptoms really to suggest sleep apnea. Because
you have this large Brazilian series from a few years ago that showed in that case, in that series at least, that something like 60% of patients with resistant hypertension had sleep apnea syndrome. So,
and I think we'll find, with these patients that have got the metabolic syndrome, they're diabetic, they're hypertensive, they're obese, they've got resistant hypertension. I think we're increasingly recognizing that if you can get them on a CPAP machine at home, that actually their blood pressure comes down. You see that with their nocturnal blood pressure improving.
Yes, please.
Yes, a rapid remark about the treatment of the patient. She had a double blockade of the renal angiotensin system with losartan and naloxone, and I think that in 2013 we had on a target results with that showed that there is an increased mortality, cardiovascular mortality in patients with double blockade. Why did it not stop there?
So yeah, I failed to mention that the spironolactone was replaced. I can't remember if it was Erase or R, but we took her off one, as you quite mentioned, that there was there's no trial data supporting being on dual ACE and R blockade in hypertension.
And just for in the pyramid, you use I think the rapid releasing form. We could not switch to a long-acting form, 105 in the pyramid that is, or to clotariodone, that is a longer-acting diuretic.
Yeah, I think those are some brilliant suggestions, particularly the idea of, looking at the half-life of these drugs and making sure that she's getting 24-hour antihypertensives. Definitely take that back as an idea.
Could I also ask you about some of the more potent classical vasodilators like hydralazine? Did this ever come into consideration in terms of your management?
So the discussion was around vasodilating her. We thought that we'd start with an alpha blocker. I mean, the idea here is obviously that she's a good patient in the sense that she takes her medication. Mm-hmm. She's eager to participate. So we didn't specifically, say, shall we use hydralazine? We started off with doxazine. But
okay. Yes, please. And then we'll move on.
Thank you. Roberto Pedrinelli, Pisa. I don't understand something in this case, in the overall context, because this patient had no hypertrophy, right? She had no albuminuria, right? And presumably she had no hemorrhages nor exudates, right?
Just grade 2.
Probably. And so how do you fit in the overall picture this? What do you think about it?
Well, I think it's quite remarkable. And like I said, 5 years later, having just read her most recent clinic letters and seeing her repeated echo and urea and electrolytes, she remains essentially with very little target organ damage, despite persistent blood pressure being very elevated. Her most recent blood pressure is more controlled, so we're looking at more 160 over 90 than we were 200 over 110 with the changes that have been made. But you're right, I don't have any bright ideas about why, and this is why she's quite an interesting patient, that she has clearly sustained hypertension without that end organ damage.
And secondly, we had a case like that, and we used urapidil, infusion of urapidil, and we found a very brisk hypotensive response, which
we discussed it actually in the context
of hypertension, because probably what you did to exclude pseudo hypertension, what you gave the drug by mouth, right?
Yeah, yeah.
And was this enough for you? Yes, probably so.
Well,
because
she
it
had all
went ahead.
5 of the prescribed medications that she was referred to us on at that time point, and her blood pressure didn't change. We haven't repeated that. Her 24-hour ABPM has improved. We did discuss whether we should bring her in for intravenous therapy to demonstrate that we can lower her blood pressure, but we didn't see a reason for that. She's not at any point presented in an accelerated fashion.
Okay, but that's it.
Let's go on to Jean-Paul. Do you want to make a comment before we move on to see what happens with the renal
I'm just conscious of the
denervation?
time and that I'll obviously have to speed up various aspects
Sure.
of this.
So
but-
last comment.
Actually, the question is, did you up-titrate your spironolactone adequately? And the reason for that is approximately 1/3 of the patients do respond to a dose between 25 and 100, and then another third to 100 and 200 milligrams, and then 1/3 of the patients require a higher dose. And if you do so, you probably can withdraw your beta blocker, and that would be very critical because if you would then find a very low plasma renin activity or active renin with an ARB and spironolactone, then you will have strong, very strong evidence for doing an adrenal vein sampling during the treatment, which will probably show you a lateralized secretion of aldosterone.
I think, again, that's a very good idea. I mean, let's control her and go back and do a metomidate scan or something else, given the ratio is very high, despite the low aldosterone on medications.
Okay.
Very dirty, filthy.
Let's see what happens as you move on with your intervention.
Now, what I'm going to do, bear in mind, we don't have long left. I'm going to essentially do this very quickly. So you'll all recall that Sympathetic Hypertension 1 had brilliant results. This was a non-blinded trial, only had one arm, which was the treatment arm. And what was interesting, apart from just demonstrating that patients dropped their blood pressure very significantly, they also performed noradrenaline spillover, which is a very difficult technique to perform, but demonstrated that on average they dropped that by 47%, and that becomes important later. It was very well tolerated in terms of safety. Now, this was a first-in-man proof of principle. The second trial that came out the year later was the first randomized control trial. So now we have a control arm. Again, not blinded. And if you have a look at the entry criteria, our patient would have fit the entry criteria. Unfortunately, she can't get in because of her ICD into a lot of these studies. But the blood pressure that got you into the trials was 160, systolic in the clinic. There was no ABPM entry in this context. 1-to-1 randomization, and they looked at office blood pressure at 6 months. They also did a secondary outcome at 24-hour ABPM. And again, very startling results. The sort of thing when you're looking at a blood pressure reduction of 32 millimeters of mercury with our patient whose blood pressure is sky high, you think, okay, maybe this is going to be useful. There was also a drop in ABPM, and again, the complication rate was small, and this was well tolerated. So in January 2012, this is around the time that this patient was in our clinic, there were some guidelines produced by the National Institute of Clinical Excellence on the basis of 2 non-blinded trials. And they obviously recognized the limited evidence, but suggested this could be done in routine clinical practice. If there was clinical governance in place, the patient understood the uncertainty, and there were mechanisms in place for audit and review. It also had to be overseen by a multidisciplinary team, or MDT, with hypertension specialists and interventionists. This was supported by a statement from many societies in the UK, including the British Hypertension Society. And what they did was use the same criteria. So if you want to do this, use the same criteria as the trials, but they fleshed out the entry or the exclusion criteria in a way that we thought was quite robust. So it mandated using ABPM to rule out white coat hypertension. It mandated a measure of concordance, which was not included in any of the trials. It mandated exclusion of secondary causes with suggestions of first-line investigations. Again, that was not in the protocol for the 2 trials. So we thought this sounded quite potentially useful. We got busy, and we got funding arranged at our hospital. We wrote patient information leaflets. We had some radiologists and cardiologists go to Europe to be trained in how to do this, and we established a regular MDT to look at patients. I know you've been standing there patiently. I think it's a good time. Is the question about?
Well, unfortunately, it's a question regarding the treatment, or mainly a comment. The fact that the patient has low renin can also be a sign that the patient probably was volume overloaded. So a different strategy would be to use as many diuretic as possible to assure a right depletion of volume. And another comment is the fact that there was no target organ damage. It can be related with the fact that aldosterone itself was low, and aldosterone is one of the major mediators of fibrosis. So that can be probably part of the story. So what I would have done with this patient is to add clortalidone, amiloride, spironolactone, and see what's happened.
Agree. I mean, obviously, with the beta blocker caveat in there, if we'd have managed to get a reading off and she was a low renin hypertensive patient, which we know makes about 20% of this cohort, it might change your thinking.
I just want to share with you that this patient description or profile reminds me of those who responded very well to renal denervation. Very well.
So,
Yes.
on that note,
What happens?
so we wanted to know, did we actually have any patients that we would offer this to that would fit the criteria? So we looked prospectively at our cohorts. These were all the patients that were booked in to see us already in 2013, so mainly follow-ups, the occasional new referral. So we had a total of 298 patients that we looked at to try and find some of these patients. The mean age was 62, they're relatively well controlled as a mean, and we put them through this pathway that was derived from the guidelines. So they had to have a clinic blood pressure more than 160, a 24-hour ambulatory blood pressure systolic daytime average of more than 150, and that was, again, from the recommendations. Rule out secondary causes, bring them in to our day unit to see what happens when we give them drugs. So of our 298, about 10% had a clinic blood pressure more than 160. But the vast, vast majority of those had either white coat hypertension, now I'm using the definition of 150 because that was what was in the guideline, or an underlying secondary cause. That 3 were excluded for various reasons, which left us with only 4 patients to bring in to the day unit. Of those, 2 failed, which means they took their medications and their blood pressure dropped as you would hope it would, which means they don't take their medications. So we were left with 2 potential candidates, and the lady I presented to you was one of those. Just a little bit more detail. The most common secondary cause in this cohort was renal artery stenosis. We had some Con syndrome, some reasonably severe CKD, and obstructive sleep apnea. 1 patient had coarctation of the aorta. Really interestingly is over half of the patients that we did ABPM in dropped their blood pressure to less than 150 systolic in the daytime. So they were all excluded. So this is what happened with one of the patients that came in, took 4 medications at 9 o'clock, and by lunchtime had a blood pressure of 130/74. So a very nice response. I mentioned we changed our protocol. We learned the hard way, as I'm sure various of you have. We gave, again, 4 medications to another patient who initially started with a blood pressure of 160/90. And unfortunately, at lunchtime, we were fluid resuscitating the patient who's became syncopal and blood pressure had dropped significantly. So at this point, we had to administer intravenous fluids. I don't know if any of you have had a similar experience when you bring patients in. It's quite scary. We learned our lesson. We don't do this anymore. Fortunately, by the end of play, blood pressure was up and they were no longer symptomatic. So we had these 2 candidates in October 2013. You'll recall what happened next. In January 2014, Medtronic, who make the Sympathetic catheter, announced that their next trial, which was the first blinded sham-controlled trial, failed to meet its primary endpoint. What do? Immediately in January, the joint consensus groups came out with a statement recommending a temporary moratorium on renal sympathetic denervation until we know a bit more. So we had to stop our very new, yet to enroll a single patient service for renal sympathetic denervation. And in fact, after a review of the evidence, that temporary moratorium has become permanent. We are still not allowed to perform renal sympathetic denervation outside the context of a clinical trial. So just to briefly look at the trial that caused a lot of controversy, the trial was performed in America. Now, up to this point, they were all performed in Europe or Australia. And they had the same inclusion criteria, but they included this sham procedure. which was really important. They did not have an analysis based on noradrenaline spillover in this trial. The results, initially, if you look at the group that had renal sympathetic denervation, they did drop their blood pressure by 14 millimeters of mercury. Not as impressive as Sympathetic Hypertension 2, but that wasn't the issue. The issue was that the sham group also dropped their blood pressure to the same degree, and there was no statistical difference. Neither was there a difference in ABPM. Complication rate was not statistically different. So a question that has taxed us as a community was, why did this fail? And we've heard a few potential reasons for that. Does anyone have any other sort of thoughts about why that trial specifically failed to demonstrate any benefit of renal sympathetic denervation?
A couple of points. I think the average number of interventions per interventionist was 2. So probably the wrong people were doing it.
So no experience from the people actually performing it.
And the other thing, I mean, there is questionable science around it still. That hasn't all been tidied up. The latest thought on it is that where they were denervating, they weren't deep enough into the artery.
Yep.
So they're saying you got to go deeper into the artery. And a lot of people probably weren't done completely in a spiral manner. So, and again, clearly the workup may have been better for these patients.
So technical problems with the procedure, it not actually achieving denervation as advertised.
Jan.
I agree, no experience. But where I don't agree is I don't think you need a sham procedure. Because you can measure the blood pressure by device, you can do 24-hour ambulatory monitoring, you can have a central reading station, and the person or the device who reads the blood pressure doesn't know whether it's an intervention or whether it's a sham. And so I really don't think that a sham procedure is needed.
And you're not alone. So there was a recent paper that was a meta-analysis that looked at that question as whether the sham design is necessary. I think from the FDA point of view, they've mandated, obviously, a sham-controlled trial because there's been a lot of discussion in the literature, and you can go back, and a lot of the things that have just been said have been brought up. One of the questions is, does it actually work? Is this approach valid scientifically? Or that this trial should be lauded because it showed the previous flaws in the other 2 trials by not having a sham that led to a positive result. There's questions about the inclusion criteria not being rigorous enough so that we are getting a very dirty cohort, and that the technical success of the procedures we heard was impossible to measure because there was no outcome measure. So the arguments are that there is the concept of the Hawthorne effect. So patients in a trial who know they've had a novel new therapy are going to start taking their medications, and that there is a reverse effect where those that didn't have the new intervention stop taking the medications. That's been proposed. And why are these patients so susceptible to the Hawthorne effect? It's because they don't take their tablets. So the Sympathy trial, which measured people's urinary and plasma drug levels without their knowledge, showed that up to 80% of patients were either completely non-concordant or poorly concordant, which means there's lots of scope for medications, the amount of medications that are being taken to change during the course of a trial. And importantly, none of the Sympathy trials included a measure of concordance at any point. There's also this question of stability of medications. If you're only on a regime for 2 weeks before you enter a trial, are you really the sort of patient we want to be entering who's really difficult to control, is on a stable regime? 40% of patients in the trial had their medications changed at some point. So it really does throw into sort of sharp relief that particular problem. Now, when we applied the guidelines, which was directly observed therapy, ABPM, rule out secondary causes, we could only get 6% of our cohort with a blood pressure of 160 or more in our new service, which never really started. In the trial, they were getting near to 40%. So I don't think they were really working up these patients sufficiently, and they got a really poorly defined cohort. Even with that problem, as we've heard, they needed 88 sites. So there's only 6 procedures done in each site. If we look at technical success, in Sympathetic Hypertension 1, they achieved a 47% reduction in noradrenaline spillover, but in animal models, you can get near to 100%. And in another sort of small study in patients that had renal sympathetic denervation, the spread of effect was enormous. So I think it's become quite apparent that the original method of denervating the kidneys in these trials was not effective at actually ablating the renal sympathetic nerves appropriately. So it's more complex, it's much more difficult than we originally thought. And not only is it more complicated, the interventionists in the third trial did not adhere to the protocol. The protocol was 4 to 6 ablations in a corkscrew manner in both renal arteries. Only 5% actually had a per protocol ablation performed. And again, that was because of inexperience. 34% of interventionists performed just one procedure. How can they possibly be expected to get it right the first time? So there's lots of issues. Now, some of the lessons that were proposed is, should we have a sham? But people have questioned that we need to include, when we're designing these trials, a robust measure of concordance, have a much longer period of stability of medication, maybe uniform, make a uniform regime that people should follow. And that we probably should only use centers of excellence. Maybe we should not have been trying to get involved in this story at all. We should have been sending them down the road to where they do them and have done them as part of the trial. Part of our naivety was that we, and our interventional radiologists, is that this is something new and fun that we can do. But actually the evidence suggests that you probably should send it to experts. And some of these ideas have actually been tested in more recent trials. So there's been 2 more sham-controlled trials. These were performed by experts, people that had done 20, 30 procedures. In the RESET trial, every single renal sympathetic denervation was performed by the same interventionist, yet they still failed to demonstrate a result. But they didn't measure concordance. I've already mentioned the sympathy trial. We know that concordance is a real problem. And when they analyzed their data according to patients that had a stable regime versus those that didn't, they started to see a signal, but only in the patients that had stability of their regime throughout. So that shows you how, when you have such a cohort that are not taking their medications, it's impossible to see the signal from the noise. And in terms of technique, in a porcine model, as we've just heard, where you ablate is really important. So the nerves become much more accessible distally. So if you ablate the main artery, but also the branch arteries, you can then bring down noradrenaline spillover to the sort of levels that you would think physiologically are going to be relevant to a clinical outcome. So before I go, this is my penultimate slide of 2 minutes, I think.
For one, yes, if we could just have comments, brief comments, so we can finalize.
I think of course, all the points that you made are important and extremely relevant, but the major fallacy is that resistant hypertension is not a physiologic entity. It is a mixture. Some patients are resistant to my treatment. That does not necessarily mean they will be resistant to your treatment, and vice versa. So I think the major fallacy is the idea that you can take a bag of all sorts of things and treat them with a specific
single
therapy.
Treatment. Yeah.
Moreover, I would like to cite a study from Streeton, I don't know, quarter of a century ago or more, who worked up, 7,000 people for secondary hypertension and ended up finding all sorts of findings, and the majority were not free from antihypertensive treatment regardless of the therapy. So long-standing hypertension is quite an elusive challenge.
Okay, we've got 1.5 minutes left, so brief comment and then we can wrap up.
Yeah, thank you for all these clinical trials. But there is one trial that was an open label trial, but with a stepped treatment during 4 weeks.
French trial?
The Denervation, but in which there were a step treatment for 4 weeks before confirmation of resistant hypertension, and then they were randomized to intervention or to a stepped escalation in treatment, and there were also a urine dosage of the treatment. And in this trial, it was positive, and there is a significant difference between the two groups, and this difference was more important in those who were adherent to treatment. So even if there is no sham procedure, we can talk about this result that is really important.
I think the key message of that trial has been incorporated into the latest spiral trials, which is medication stability is vital in order to see a signal. And that's really, so what I wanted to show is, because we're all missing right now the update from Spiral. You've all chosen to come here. You didn't want to go to renal sympathetic denervation, but you got some anyway. Apologies for that. But what they're trying to do is integrate all of the lessons that have been discussed in the literature, including what you've mentioned. The first is their new catheter is supposed to be easier to achieve. Instead of a 90% failure rate, they should get 100% success, and that it will be applied to the main and branch arteries. And they're including lots of things that we all think are important. So patients are going to be on 3 specific medication classes in the same way that was done in the French study. There's going to be 6 weeks stability instead of 2. They are included directly observed therapy. They're also measuring drug levels throughout in urine and plasma by mass spec. They're restricting to 1 procedurist per site so that people get the experience that's required. And there is an outcome at 3 months, but they're also going to look at an outcome at 36 months. So they really have integrated all of these lessons. Therefore, this trial, you would hope, should be rather definitive, although I've just spoken to Medtronic reps, and apparently this may come out at ESC, which would be interesting. But interesting to have an off-med study as well. So how do you deal with this problem of concordance? Well, maybe you should perform this on people that aren't taking any medications at all. I think this is quite controversial, but this is what they're doing. They're taking patients that have the same blood pressure off medication and performing the study. The rationale for this is it's the cleanest cohort where if you're going to see a difference, you'll see a difference. This is not unique. Other companies who have slightly different technology are doing similar things. And in fact, if you are interested, Recall have their update tomorrow about their Radiance trials. They are using an on and off med strategy as well. Really, I think, to try and offset this idea of poor concordance. So from our patient's point of view, her blood pressure is slightly better. I'm going to take back some of the excellent recommendations from everyone on the floor about how we might manage her better. She can't be enrolled in these studies because of her ICD. And I think as a centre, we feel that we were very naive in the first instance of getting involved in this bandwagon because we didn't wait for a blinded randomized control trial before setting this up. And I think that's a real lesson. If this had been a new drug, there is no way that it would have gotten this far and people have got so involved like ourselves. So we've learned our lesson, and I think the lessons are generic. I think these need to be applied to any new device or approach to hypertension moving forward. So obviously I'm out of time. Thank you very much indeed.
Dr. George, thank you so much. And with that, we will close the session. Thank you.